Welcome everybody. Welcome to Houston, Texas. This is rodeo time in Houston, deep in the heart of Texas. But we're going to take an hour out of the rodeo time and talk about AFib. This is CV Live coming to you directly from Methodist Hospital at the Texas Medical Center, and specifically DeBakey Heart Center. My name is Dr. Randall Wolf. We're in the studios here at DeBakey, and as some of you know, most first Tuesdays of the month, 5 p.m. Central Time, we talk about atrial fibrillation. Today is no exception. I have two special guests with me today. The topic is frequently asked questions. We do this from time to time because there are many frequently asked questions. And Sandy Schremeyer, who's going to join us here in a minute, tells me that despite her best efforts, people ask the same questions. So every once in a while we like to clear the air and try to catch people up who maybe didn't listen a year ago to some of the frequently asked questions. And I'd like to start out by saying, if you're on your phone, you can go to 37607 and in the box put DeBakey, D-E-B-A-K-E-Y, and you can ask your question. If you're on a computer, go to pollev, P-O-L-L-E-V.com, enter DeBakey and ask a question. Please don't wait to the end of the hour to ask your question. If you have a question, we will take it, but we prefer to start lining up the questions as soon as possible. So on your phone or on the web, ask any question. There are no bad questions. And almost always, if you ask a question, there were probably 20 other people that wanted to hear an answer to that same question. So don't hesitate to do that while we're talking. We'll line the questions up, and we'll try to get through all the questions by the end of the hour. There are also some good resources on wolfminimaze.com and also the Facebook site, Live AFib Free, Wolf Mini Maze. And some of them have been edited by patients, and we'll talk about that as we go along. They're very good resources for you. In addition, in the studio, to my left is Paul Chisholm. He's 68 years old, and I just saw him in the office a few hours ago, and he was kind enough to come by the studio with me and give you some very updated information about him that might help you if you're on an AFib journey. So first I'll introduce Sandy Schremeyer. She's the administrator of the Facebook site. Sandy, thanks for joining us, as you have in the past from time to time.
It's nice to be here.
And you're looking very nice today. What city are you in today? I know you have two different homes. Where are you right now?
I'm in Grafton in Wisconsin.
Wisconsin. Okay. How's the weather?
We have no snow. It's been the mildest winter we've ever had on record.
Okay. No. That's why you're smiling, huh? Although you probably like the snow, don't you?
Not really. Not so much anymore.
Sandy, how many people were on the Facebook site when you started working on it?
2001, we had 9 people. We now have, it's close to 2,500.
So now we're at 2.4K. I say we, right, but really you've been fantastic at helping people with their journey at AFib, whatever it might be. And I'll make a point because otherwise I'll forget it. I mentioned to you this before, but as you pointed out, there are people on the site that have had procedures, ablations, surgeries that may not have been performed at Methodist Hospital, correct?
Correct.
I mean, you're open to everybody. It's not just for people that come to see me.
We are. The whole idea is AFib, no matter how we do that.
Yeah,
I mean, normal sinus rhythm.
Yeah, and there are people on there that have had procedures done as far away as Tokyo, Japan.
Correct.
Yeah. To my left is Paul. Paul, thanks for joining us today.
My honor.
And I guess as a start, let people know how you found Sandy and ultimately me.
Sure. I had been through quite a journey with my AFib. I was first diagnosed with AFib in 2016 during my normal annual physical with my primary care doctor. Told me, you have AFib. I didn't even know what, I'd never heard the word AFib, didn't know what it was. He sent me over to see a cardiologist, and in that time I started doing my research. And one of my daughters is a pharmacist, and so she kind of helped me a little bit, told me about the CHA2DS2-VASc scale and all these different things. And I went and saw that cardiologist, and he told me that he didn't believe in ablations, and he just believed in giving you medicine and blood thinners. And at that time, I researched that it said the catheter ablation was the gold standard on there. This guy doesn't even believe in catheter ablation. And so I did my research, and I went to a big famous hospital in downtown Boston with a national worldwide reputation, where they have a whole EP wing, and I went and saw a specialist who treated AFib. And we started the journey there. And I'll summarize quickly. 2017, first ablation. Couldn't finish it because the temperature started to rise near my esophagus. Mm-hmm. Probably out of AFib for maybe a month or two or whatever. Came back and do the second ablation to finish what we couldn't finish in the first one. Out of AFib for a while, maybe till 2019, I went back into AFib. And we had, at the same time, I also had 9 cardioversions, so it just was like a continuous fight against this darn thing. And we were trying different drugs, and they all ultimately would fail. So we got to the point in 2019. I had the third ablation. Can I tell the story of what happened on my second ablation with the TURP? Sure. So there was kind of a terrible thing happened to me at my second ablation. I had an enlarged prostate, and the wrong kind of catheter was used for an enlarged prostate, which ended up piercing my prostate and causing me to bleed internally. I was stuck in the hospital for a week. I had 4 transfusions. They couldn't stop the bleeding. I had cardiology arguing with urology about getting me off the blood thinners so they could do a TURP. No, we can't do that because I might have a stroke. Finally get out, and I was in terrible, terrible condition. I was at home. I had lost all kinds of weight. I had no color. I had no strength after a week in bed. And I had at-home nursing, at-home physical therapy coming. It took me a couple of weeks before I could even have the energy to get up and take a shower. And I remember that first shower, I had to go lay down for a half hour before I could get downstairs. It was probably the lowest point physically I had gone through. Well, so out of AFib for a while now after that one, and the AFib comes back in 2019. And we start again with another ablation. This time they put me on Multac, and we got pretty good results for about a year and a half, 2 years, where I was in sinus rhythm. But once again, the ugly head of AFib came roaring back, and I go back into AFib. So I go back and see my doctor, and he said there's little chance a 4th ablation would be successful, that there was little else for him to do, and I'll summarize in my words, good luck, take Xarelto. And that's where I was. And then we get to the last year. So I'm on Xarelto with little problems for a while, but I started to bleed. And I went to see my urologist, and he explained because I'd had the TURP in 2017, my prostate would never fully heal, and it was going to be prone to bleeding. So over time, the bleeding became more and more frequent until 10 months ago. The bleeding was getting very, very frequent, and I decided, I looked at the CHA2DS2-VASc scale. I was still a 1 on the CHA2DS2-VASc scale. I said, I can take a break from the Xarelto, see if I can get my prostate a chance to heal, and stop the bleeding, and then I'll resume the Xarelto.
And you were out of rhythm at the time.
I've been out of rhythm for 3 years now. Yeah, I've been out of rhythm since 2021.
So you're between a rock and a hard place.
Yeah.
They say if you stop the blood thinner, you might have a stroke.
Yeah.
But if you don't stop the blood thinner, you're going to bleed to death.
Yeah. I didn't know what to do. So my wife had just retired. I was a federal law enforcement agent, and I had been retired for quite a while. And my wife retired. We went to Nashville to celebrate. And we're walking down the street, and she's next to me, and all of a sudden, I can't see her. I lose the peripheral vision from here to here. And I'm freaking out. What is this? And I'm Googling it, and it says, oh, it usually comes back, but it's a sign of something more serious may have happened to you.
So you were having a mini stroke.
Little did I know, but I'm having a mini stroke. So sure enough, the next day my vision comes back, but I followed up with an ophthalmologist back home, and my vision was fine. When I told him all about the AFib and having taken the break from the Xarelto, he says, you may have had a mini stroke, go see your doctor. And he wrote up a report and sent it over to my doctor. My doctor got me right in and ordered up a bunch of tests, and it gave me some of the options that it might have been in the mini stroke because of the AFib. It could have been a mini stroke from a piece of plaque from the carotid artery, or it could have been a migraine. It could have been an ocular migraine. And we did a lot of tests, and at that time I'm still bleeding. Now I'm afraid to not take the Xarelto, so I continue to bleed and take the Xarelto, which leads to my prostate get infected. And I get a phone call that Friday night from my urologist telling me, Paul, your PSA is 42, but don't worry, I think it's just the infection. Well, let's come on into the office, let's see this thing. And everybody is like freaking out, especially me. And my doctor said, after we took 2 rounds of antibiotics to knock out the infection, we finally get a handle on that. And I'm talking to my doctor via the computer, and he suggests to me that I get my LAA closed. Well, I have to go to Google and say, what is the LAA? And I see that it's the left atrial appendage enclosure. So I have to research the left atrial appendage closure. And I find a lot of different options out there. And I see that the Watchman device was a possibility, had been co-invented at Mass General. I liked the idea of the Lariat down at Johns Hopkins. And I come across a Dr. Wolf in Houston, Texas, who closes the left atrial appendage. And I come to Dr. Wolf's website, and I start reading it. I see about his videos on YouTube, and my wife and I start watching Dr. Wolf's YouTube videos. And as a former investigator, you can trust me when I tell you I investigate the heck out of things. And I've got a list of questions, and I have a stack of paper. And as I'm going through the process, and I'm on the website, and I start watching the videos, I learned so much. I joined a friend of mine who has AFib told me about the website that Sandy runs. I joined the Facebook group. It was incredible how much information there was out there that I could learn with minimal effort, if you can find it.
So he's saying thank you, Sandy.
You're welcome.
Well, let's stop there for a second. We have questions coming up. I want to repeat again. If you have a question, frequently asked question, any question, we'll put it up on the screen again. Thank you, Mr. Producers. If you're on your phone, go to 37607. In the box, put DeBakey. If you're on your computer, go to pollev.com, enter DeBakey, and ask your question. Sandy, let's take a few questions. And by the way, I know you have some too. I'll take a couple off of here, and then I'm going to hand it over to you, and then we'll go back to Paul.
Okay.
I have a Wolf Mini Maze scheduled for the end of October. I heard you may have added another surgery day to your weekly schedule. If so, would my date be moved up, or would it remain the same? Well, you are right. We have added another day each week, Tuesday, which I did not have before. So that's opening up a couple of spots a week, not every week, but most weeks. So the schedule has become quite fluid. I have been asking patients to get in the queue. Don't worry about the date. And if you'd like to be on the move up list, say so. So there's a good chance you can be moved up if you're willing to do it. Sometimes Melody and Christina get a little perturbed because they call someone and they go, oh no, I can't do that. I can't move up. But if you really think you can move up, tell them that, and there's a good chance you will move up. And some people move up a lot. You moved up too, but you were in a precarious situation.
We had our Zoom conference on January 2nd, and my wife and I had rented a house down in Key West. and you offered me a spot in a few weeks because, as you said, I was between a rock and a hard place. I needed to be on your urgent list.
Yeah.
And unfortunately, we couldn't make that because of the Florida commitment. But you got me in February, which was, believe me, when I would tell you, when I was researching this, and I had the thought of, I had a mini stroke. I know the odds of having a regular stroke are great within the next year.
Right.
And I realized, oh God, I have a year wait before I can get in and get the mini maze. So to me, believe me, it was a miracle when you said I can get you in February. It was like, oh, dear Lord, thank you.
Well, we gave you one of those new dates because, I mean, the biggest, you're right, the biggest risk for a stroke is that you've already had one.
Yeah.
And you were there.
Yeah.
And you couldn't take the blood thinner.
Yeah.
And you'd had infections because of all this, so you had a real urgent situation. Yeah. One more question here. Has Dr. Wolf done a mini maze on a patient with left bundle branch block? Yes, of course, that's very common. Does the EKG diagnosis limitation cause any challenges? No, it doesn't. It's very common as you get older to develop a bundle branch block. And I think you have to keep in mind there are two different systems. There's your intrinsic cardiac system that's your own pacemaker, your God-given pacemaker. And the way I look at it, your God-given pacemaker is happy to beat at 60 beats a minute your whole life. But a long time ago, we evolved maybe to try to get away from a lion or a tiger, so your brain tells your pacemaker, speed it up right now. Don't wait till I'm running 5 minutes. I want you to speed up now. You know, you don't have to be the fastest in the pack, but you can't be the slowest, right? Yeah. So we're given this system, autonomic nervous system, that speeds our heart up and also slows it down. So it's not always beating at 60 beats a minute. The bundle branch block and that sort of stuff, that's your intrinsic heart. The mini maze doesn't do anything with that. The mini maze is affecting the nerves that come from your brain and your spine and even your own heart that are telling it to speed up or slow down. And I believe what happens with AFib is you start getting mixed messages to the pacemaker. So the autonomic system is kind of overloading your system. And this ablation is really a partial cardiac denervation. It decreases some of that input, that autonomic input, but it does nothing for that pacemaker that's going 60 beats per minute. That's still okay. Sandy, I'm going to turn it over to you. You probably got a laundry list, but we'll try to get through a few of your pet peeves that keep popping up.
I actually had a few people that wanted me to ask you a few questions, so I'll just start with a few of those.
Okay.
I have flutter and AFib, and if I have to wait a year to have a Wolf mini maze, if I choose to have a catheter ablation before that, will you still do the mini maze in a year?
Okay, good question. And it's sad that's happening. And again, we're doing everything we can to move people up. My general rule is you should wait about 6 months after a catheter ablation to have a mini maze, and vice versa. Generally, the catheter ablation heats up the inside of the heart tremendously, creates scar, but for a while it's kind of mushy, if to use a general term, a non-surgical term, and that tissue is sort of fragile. So it wouldn't be safe to go in and do a mini maze. Usually I say 6 months, sometimes we push it up to 4 months, but 4 to 6 months after a catheter ablation, you need to wait to let things settle down. One, because the tissue's friable, that's the medical term. The other reason is maybe the ablation will work. Give it some time. It's reasonable to give an ablation 6 months to a year to see if in fact it would work. So if someone decides they want to go the ablation route, they're adding probably at least 6 months to anything else that might be done. The downside is there is scar that's created with a catheter ablation that's not created with the mini maze. And as I say commonly, with the mini maze, the incisions are bigger on the skin compared to a catheter ablation. but there's far less burning of the heart compared to a catheter ablation, because we're just making lines and stopping the electrical activity on the outside of the heart all the way to the inside, but just as a line. So I hope that helps. You think that answers the question, Sandy?
I think what the person was wondering was if they were in normal sinus rhythm after the catheter ablation, would you still do the mini maze?
No, I wouldn't.
Right.
Now, that's assuming they got off their medications. If they're still on amiodarone, they're still on Sotalol, they're still on one of the antiarrhythmics, then you'd want them also to get off the antiarrhythmic to see if they stay in rhythm. But of course not. If they're in rhythm and off antiarrhythmics, then they're good. They don't need anything else.
Right.
What do you got next?
I had a previous stroke, and I have lone AFib, but the echocardiogram shows that I have a atrial septal defect, and my cardiologist says that even if I have a Wolf mini maze, I'll have to take a blood thinner for the rest of my life. Is that correct?
Usually not. Now, an atrial septal defect is a hole between the right atrium and the left atrium. Before we're born, that we have that hole. It shunts the blood, and then in most of us that hole closes after birth. But in many patients it does not. Sometimes it's called a PFO, patent foramen ovale. If it's a little bit bigger, we call it a atrial septal defect, or ASD. Those can be closed percutaneously. Generally, the cardiologists don't do that if they plan on an ablation. I did a patient last week who had an ASD closure, and then they tried to do a catheter ablation, but they could not do it because the ASD closure device prevented them from getting from the right atrium to the left atrium. But generally, the answer is no. And in fact, many people that have had multiple ablations now have an ASD. It's what we call an iatrogenic ASD. It's from the previous ablations. I wonder if this patient's had previous ablations.
I don't think so. I know I did. I had a PFO after my second ablation, and I told you about that when I came in. And you said that you would look for it when they did the TEE, and it had sealed, thank goodness. But yeah, I had one too.
The small ones are usually shunting in a certain way that it's not dangerous. So generally, I don't worry about those. If it's really a larger one, after the mini maze, it can be closed percutaneously, or even before the mini maze. Percutaneously means up through the groin with a device. The most common was called an Amplatzer device. Carry on. You're on a roll.
Yep. Okay. I've got another quick one. Can you have the Wolf mini maze done if you have chronic leukemia?
Chronic what?
Leukemia.
Yes, you can. We've done the mini maze in that situation. We like to talk to the hematologist, oncologist, make sure the situation is stable. In many instances, it's helpful for them because they can decrease the blood thinner that the patient's taking. But the short answer is yes.
Okay.
You want to do one more?
Okay, sure. When you ablate the ganglionic plexi, do you actually destroy the nerve, and does it have any effect after exercising?
Yeah, we do try to destroy or make it non-functional. These ganglionic plexi are where the nerves make a connection on the heart. Now, keep in mind, each human has thousands of these little connections on their heart. We're concentrating on the ones that are around the pulmonary veins. In my opinion, what happened, Dr. Hassegair burned on the inside of the heart, and it worked, and I think he burned deep enough to get some ganglionic plexi. And I don't think it's because there are these muscle sheaths on the inside of the heart that are active. I think he burned the ganglionic plexi. So we're doing a very specific area, and that's been very helpful. We're not denervating the whole heart. It's just the area around the left atrium, and that's where you get initiation of AFib. What are the key different? Now I'm going off the screen, Sandy. What are the key differences between the Wolf mini maze and other totally thoracoscopic mazes? Example, 5-box TT maze. Very little. In the Wolf mini maze, we target the nerves. We test the nerves before and after we do the ablation. I don't know that anybody else does that. The main other difference is you're ending up with 5 small incisions versus 2 small incisions and a bigger incision. Early on, Bill Schneeberger, who was my associate at the University of Cincinnati, and I performed mini mazes where we did them totally thoracoscopic. We found that the patients had more pain post-op than they did with the regular mini maze. We also found it took longer time to do it and was more taxing on the operator, the surgeon. So I still think the safest way is the way that I currently do it and have done it for many years. It's okay to do the all totally thoracoscopic. It's harder, it has a higher complication rate, and I'm not convinced that the recovery is any better. Dr. Wolf, have you seen a trend in more cardiologists and EPs referring patients to you for the Wolf mini maze? Well, it kind of depends on the week. Every once in a while we have a good week, but I'd say overall, generally the electrophysiologists are still doing ablations, and at least the patients I see were not told that maybe there was another option, which I guess goes back to you, Paul. That was kind of, wasn't that where you were then?
It was all on my own.
It wasn't mentioned to you by...
No, I don't think anybody knew about it.
It was through your own...
It was, digging into Google and saying, what's the left atrial appendage and how do you close it? What does that mean?
And is it true that one of the reasons that led you more towards the surgical procedure was that it was possible not only to close the appendage, but to also possibly get the heart back in rhythm?
Right. On one of your lectures on YouTube, you mentioned that even somebody like me who's been in permanent AFib for 3 years, had 3 failed ablations and countless cardioversions and all the different meds, I was still in a 75% chance of getting out of AFib. So I could get off Xarelto and I could have a 75% chance of getting out of AFib. That made more sense than the Watchman device and more sense than the Lariat device. Let's go give this a shot. Mm-hmm. Plus, one of the other things I wanted to mention was when I developed AFib back in 2016, I also noticed that I had digestive issues. And when I went into the hospital to visit with my EP and I was telling him about that, he told me that there was a known connection between AFib and the vagus nerve. And as we went through our relationship, I said, can we isolate the vagus nerve? And he told me that there was no way to isolate the vagus nerve because it would lead to digestive problems. And now, fast forward to this past 6 months, and I'm watching Dr. Wolf's videos, and he talks about vagal nerve AFib. Yeah. And I'm yelling to my wife, daughter, come look at this. This guy can get me off of blood thinners. He can cure my AFib if it's vagal AFib, and he has a 75% chance of getting me out of back into sinus rhythm. It was like this was made. It was the stars were lined up for me to find you, Dr. Wolf.
So, well, we'll give him the kicker here. How long ago did you have your surgery?
Last Tuesday.
It's been 1 week. I saw you in the office earlier today.
Yes.
And we did an EKG, perfect sinus rhythm. You have a link. We put a link in at the time of the procedure. You've been in rhythm.
Yeah.
And I went into the room to tell you that, but you already knew, didn't you?
I knew because I have tinnitus and it echoes my heart. It's like I have a stethoscope on 24 hours a day. I can hear my heartbeat right now, as a matter of fact, and I can hear it boom, 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 right on rhythm.
You don't really need the link, do you?
I could just call you.
Sandy, back to you.
I also have that pulsatile tinnitus, so I also have my EKG in my ear at all times, Paul, so I know exactly what you're talking about.
Isn't it wonderful?
Do you really?
I do.
Oh, wow.
I do.
You know, there have been several people that have told us that after they've had this procedure, the mini maze, that their digestive disorder got better. I mean,
absolutely. Absolutely.
I'm hoping for it.
There's some other ones that are really strange, but it's more than a coincidence. a farmer I operated on told me a year after his procedure, he was in rhythm, but he said, "Doc, you cured my cold hands." He said he had Raynaud's. If it was less than 50 degrees out, his fingers turned white. And he said now he can go out in the middle of the winter, not even put on gloves, and he's fine.
Wow.
That's not a coincidence. This autonomic system of the body is very intricate and has all these feedback mechanisms. And we have not been focused on those for a long time. I have an article that's this thick. It's a good treatise on the autonomic nervous system, but we don't use it clinically very well, and I think we should, particularly in the case of AFib. How about another question from your list, Sandra?
Okay. Can you explain why atrial flutter shows up after you've corrected AFib?
Yeah, so that's another good question. In atrial fibrillation, the top two chambers are just wiggling. The bottom two chambers are beating. That's what keeps you alive. They have to beat, but they're not in rhythm. It's beat, 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 beat. They're not synchronized to your pacemaker. In atrial flutter, the top two chambers are beating, but they're beating too fast. So generally they're beating 2 times or 3 times faster in the upper chamber than the lower chamber. So the upper chamber is going beat, beat, and then the lower chamber goes beat. So they tend to be a fairly regular rhythm, but it's too fast. Why does that happen? Well, we don't know exactly. It's very common after catheter ablations. A lot of the people that I see, and maybe even you had it, Sandy, you have an atypical left atrial flutter because you have these areas of the atrium that are burned and areas that aren't burned all the way through, and it creates a rather chaotic movement of the nerve impulse. So it may be that. It can happen in patients who've not had prior ablations. They can have flutter post-op after the Wolf mini-maze, much less likely compared to patients who've had multiple ablations and then the mini-maze. We don't know exactly why it occurs, but it still may be some incomplete connection somewhere. The good news, at least here at Methodist, is that we've been very successful in going back 6 months after a mini-maze and zapping a flutter spot that some rogue spot that just won't go away. I work with Dr. Fahed here. He's been incredibly successful in mapping the left atrium, finding some rogue spot, and zapping it, and that seems to work.
Could I ask you a question, Doctor?
Yeah.
I know when you looked at, you told me after mine that after the 3 ablations up in Boston, that the interior of my heart was all burned up and you had very little to work with. If I was in a month have a bit of flutter, would you have to go in there and try to do another ablation?
Yeah. So Paul's asking, what if he has a little bit of flutter in a month? Well, it depends, and Sandy knows about this too, because she was plagued by it for about a year after the mini-maze.
Almost. Mm-hmm.
But we decided to watch it, right?
Yeah, I went into persistent flutter afterwards, which is common for several people. And at 4.5 weeks, I did have a cardioversion. And then after that, I just had, it came and went, but it lasted for almost a year. But it just finally burned itself out, and I've never had it since.
Generally, the scenario is exactly as Sandy said. If you do a cardioversion 4 to 6 weeks after the mini-maze, that usually takes care of it. In cases where it doesn't, then it's 6 months after a catheter ablation has been very successful. That was kind of a roundabout answer to the question. Did we get it though?
I think so. Okay. Yeah. I do have another one. Oh, go ahead.
Go ahead.
After a successful mini-maze and you're filling out medical questionnaires, do you have to check yes under heart disease?
Oh, wow. I don't know the answer to that question. I mean, the first thing that comes to mind is cancer. If you are 5 years out from cancer operation and you're cancer-free, they call that a cure. But yet, generally, cardiologists say, once you've had AFib, you have AFib for life. I do have patients that are 20 years out that have no further AFib. So where do you draw the line? I don't know the answer.
I generally check no, and then when it goes under the surgical questions, I put that I have a minimally invasive procedure to correct AFib, and that AFib is resolved. That's what I put.
Fair enough. I like that. Yeah. So the Facebook group has lots of accounts of challenges after the mini-maze. Some challenges happen right after the mini-maze. Others happen weeks or month after the mini-maze. Well, Paul had his surgery a week ago. You're out walking around feeling pretty good.
Yeah.
What are the factors that might make the recovery more difficult? One is weight.
Yes, that was a shocker.
I understand why people don't want to mention that on the Facebook site, but I think if you're morbidly obese, it's harder to move around, it's harder to get going, and it may delay your recovery. It also makes the procedure more technically challenging. The instruments, I only made them in one size, so it may take more manipulation to get to the spot where we need to go, which could then cause more pain post-operatively.
I thought you were talking about the weight you put on during the surgery.
No.
I put on 12 pounds. I feel like the Pillsbury Doughboy.
It could also be that there's scar in the heart. One of the patients I did last week, the one that had the Amplaster device for the ASD, her heart was all scarred in. I think maybe there was a puncture of the heart along one of the procedures she had. That makes it more difficult to do the procedure and can make the recovery more difficult. There are other factors. Sandy, you want to add to that? You deal with this all the time on the Facebook site.
You know, I think the thing I always tell people is trust in the procedure, trust in it's time and patience. Time and patience wins this race. We all get there. We all get there in our own time. And some things go on in between, and it's all normal. But, you know, it's different for everybody.
You hardly had any discomfort, right?
I didn't. I didn't have any discomfort at all. I was sore from the incisions, but I didn't have any discomfort. And I took ibuprofen. Others needed stronger. I didn't.
Okay. Would you do your procedure on an otherwise healthy 84-year-old male with an otherwise healthy heart? Yes, generally yes. There are a couple of things that I look at that have been very helpful in predicting the outcome of the procedure. One, how big is the left atrium? Because over time the left atrium enlarges in AFib, and generally if it gets over 200 milliliters, the chances of staying in rhythm after the procedure begin to go down, but they don't go down precipitously, they just go down a little bit. And what's the goal in 84? For a lot of 84-year-olds, their main goal is to get off a blood thinner.
Yeah.
If you can stay in rhythm, great, but you might have been in that boat.
Sure.
You wouldn't be completely disappointed if your main goal was to get off the blood thinner.
My goal, because my main goal was to get off the blood thinners.
And not have a stroke.
And not have a stroke. And I was afraid, after all the disappointments I'd had, because we had tried everything that supposedly was out there, I was afraid to hope to get out of AFib, because I didn't want to be disappointed again.
Yeah.
So I tried to convince myself, I'm going just to get off the blood thinners. And if I get out of AFib, that's just a bonus. But deep down, I wanted to get out of the AFib.
So the short answer to the question is yes, but we would look at the echo. We would make sure there are no blood clots in the heart currently. That would be a contraindication to proceeding. But as I said before, and Sandy knows this, you have chronologic age and you have physiologic age. Chronologic age is what you put down when you write your age. Physiologic age is how you feel. Yeah. And there are lots of 84-year-olds, and I've operated as up to 90-year-olds, but frankly, they didn't look like they were 90-year-olds. Yeah. They looked more like they were 74. Yeah. So it depends, but the short answer is yes. What's the reason behind not being eligible for mini-maze and LAA closure after mitral valve or aortic valve? Well, I got to break that up. It's mitral valve. I've done a lot of patients who've had aortic valve. We can do the mini-maze. If a patient's had a mitral valve surgery, an open procedure or a minimally invasive procedure, then incisions have been made on the left atrium quite close to where we need to work. And that scar is tough. And it's dangerous, I think, to go there. So if it's been a mitral valve replacement, it's a contraindication. If it was aortic valve replacement, it's okay. If it was a TAV, percutaneous, we've done many of those, it's okay. It's mainly the mitral valve because of where the incisions are located from the previous surgery. Let's see. Do you have an opinion on pulse field ablations? I do. Are particles going to the brain still concerned with pulse field? Answer is yes, you're still burning. Pulse field is becoming very popular because it's much faster. And that's good for the patient and it's good for the electrophysiologist. What they did in 4 hours, maybe they can do in 1. I think that's great. But if we look at the mid-term results of pulse field with respect to recurrence of AFib, it's no different from radiofrequency that's been done before. And that makes sense because they're still burning from the inside and they may not be getting all the way to the outside and affecting the nerves. So I predicted that although it would be faster, the results may not be any better. It may be a little safer though. Now they boasted it doesn't injure the nerves. Well, that's good and bad. It's good that you don't injure the phrenic nerve, which is your breathing muscle nerve, but it's bad if you don't injure the nerves that are the autonomic nerves that are causing the AFib. So I think the jury's still out on pulse field. Like many new things, there was a great deal of excitement about it. It's somewhat now backed off a little bit because the midterm results aren't any better than radiofrequency. Back to you, Sandy.
What happens if I need a cardioversion at home and my hospital will not do one unless I take a blood thinner 30 days before and 30 days after, even though I told them I've had my left atrial appendage clamped?
Yeah, we run into that quite a bit. And there are two options. One is suck it up, take the blood thinner for a month, stay home, get the cardioversion. They may also say we need to do a transesophageal echo to make sure that the clip hasn't slipped. These clips don't slip. Now the cardiologists think about that because the Watchman can slip and the Lariat can slip, but the device that we use, either staple or the clip, don't slip at all. That's option one. Option two is come back here. I've had people come back here all the way from Alaska because it was just easier for them to jump on a plane, come back here, have the cardioversion, turn around and fly home. So I think those are the two options. That sound right, Sandy?
Yeah.
Yeah. That's
they just needed to hear it from you.
I wanted to mention before we run out of time, and is Ross's information on the Facebook site?
Yes.
That matrix?
The matrix? Yes.
Which he did what, like
file.
6 years ago or something, or 5 years ago?
Oh, longer than that. I'm 6 years, so he's closer to 8.
8 years. So that's available on there, and that's a nice way to look at the different options available. And now more recently, I want to say Sean, the ear, nose, and throat surgeon that I interviewed last month, is his stuff on there or not?
It is. Everything's in the files. If people just look in the files, there's a wealth of information there.
Because I think those two resources are very valuable. One from
stuff is there too.
A skydiver who had AFib, and the other from a otolaryngologist surgeon who had AFib, and how they went through the process. Did you see any of that?
Yes.
You did see it?
I watched most of them, yes.
Okay.
That was, the ear, nose, and throat guy.
So those are helpful.
Yeah.
Sandy, you got any more on the list there?
I do. I have quite a few. I'll save them for next time, though. The one question I get all the time, and I know you've answered it before, but will the mini maze correct both my AFib and my flutter?
It depends. If it's left atrial flutter, which is usually from a catheter ablation, the answer is yes. If it's right atrial flutter, which is typical flutter, the flutter that EPs saw before they started doing catheter ablations, no. And in fact, catheter ablation is the preferred treatment for right atrial flutter, excuse me, also known as typical flutter. So I look very carefully for that. If I see that the patient has primarily right atrial flutter, then I recommend a catheter ablation.
Right.
Let's see. Had Wolf Mini-Maze after 10 months experiencing flutter on and off, now being totally off amiodarone, often in rhythm. Local EP says will not do cardioversion. Feel free to come back here. I do the cardioversions myself. I do not, if the appendage has been closed, I do not require an echo. I'll call it a transesophageal echo, or TEE, putting the echo down through the throat. I do not require that you be on blood thinners, and I've been doing it that way for over 10 years. Knock on wood, no problems with that ever. If you're on flecainide, how long before the mini-maze you switch to amio? Nobody knows the right answer to that. I think 2 months is adequate. It turns out that the heart calms down with amiodarone, more likely to stay in rhythm after the mini-maze, and then after 90 days wean the amiodarone. So usually I recommend you switch 2 months before. I've had 2 patients within the last 2 weeks who were long-standing persistent AFib. They had not been in rhythm for a couple of years. We started the amio on the low dose, and after 2 or 3 months, they both converted to sinus rhythm.
Wow.
Which means they'll probably do very well with the mini-maze. Let's see. Quick comparison, hybrid convergent versus mini-maze. One of my pet peeves. I first did a convergent procedure in Europe, in Poland. It must have been 14 years ago now. And essentially the surgeon burns the back of the heart, the back of the left atrium. It's not focused on the nerves. Sometimes I think it gets some of the nerves, and that's why it's better than catheter ablation alone. But the procedure still depends upon the catheter ablation to do a lot of the work. So therefore, I don't expect to see great results. It'll be better than a catheter ablation, but still not that great. And you're burning up the back of your heart. You don't need to. You need to go to the nerves. So I'm not a fan of the convergent procedure. And the downside is, after a convergent procedure, it's very difficult to do a mini-maze. In some cases, impossible because of the great scarring from burning the whole back of the heart. There was a patient who was on here a few months ago, Ty Smole from California, and he did have a convergent procedure out west, I think in Phoenix, and we were able to do his mini-maze completely. But there have been others where it's been so stuck down it's dangerous. So it's a relative contraindication to do a mini-maze after a convergent procedure. Will removal of the appendage, can I get off blood thinners and cholesterol meds? You can get off blood thinners unless you're on the blood thinner for another reason. Cholesterol, no, that's completely different. And that's not related to whether or not you're in rhythm or not. And let's see, what's the time being notified of a move update, and when would need to be in Houston? I'm in Florida. Usually about 2 weeks. Usually about 2 weeks. It can't even be a week. I think in your case it was 3 or 4 weeks.
Well, you would have given me the opportunity to come in 3 weeks.
Yeah.
But I couldn't at the time, so we
Yeah.
had to put it to the next month.
Yeah. So I'd say a couple weeks. Let's see. Let's go back to you, Sandy. We're running out of time, but do you have any burning ones that really get your goat from time to time?
Sleep apnea. If I have the Wolf Mini-Maze, will it cure my sleep apnea, and can I stop my CPAP machine?
Well, you know, I used to think that was not a very smart question, but in fact, it's a really good question. And after I've read a lot on ganglionic plexi and autonomic nervous system, there is a GP on the heart medial to the superior vena cava that's called the sleep apnea ganglionic plexi. Huh. So I've been trying to ablate that when I do the right side of the mini maze. Now, whether that turns into anything or not, it's too soon to say. But some people have found a ganglionic plexi that may relate to sleep apnea. Generally, I say the answer is no, but the jury's out.
Okay.
Paul, some closing comments from you. Again, thanks for joining on short notice.
It's been fun.
You're a great speaker. We appreciate it.
I would like to make one point. After I get out of the hospital, we're back to my brother's house where we've been staying. And I think it was 1:30 in the morning, and I'm going through all the notes in the MyChart system. I'm looking at Dr. Wolf's notes on my procedure. And now, granted, now you have to remember, I've had 3 catheter ablations, and and Dr. Wolf had told me the inside of my heart was all burnt up. And I'm reading Dr. Wolf's notes, and in his notes, the pulmonary vein is still active.
Yeah, that's the problem. That's the same thing we had with Sandy and so many others. It's very difficult. It's technically very difficult to get a complete isolation of the pulmonary veins from the inside. Now, you may think you have it because you touch your catheter down where you burned and you don't transmit electricity, but that doesn't necessarily mean you can't get it from the other side.
Yeah.
And that's the problem, I think.
Yeah.
Sandy, any other questions you want to get out there?
No, I think if we can save them for next time.
Any recommendations to people that are interested in the website? I'm sorry, in the Facebook site.
They just simply have to go to just type in Wolf Mini Maze Live AFib Free and just join.
Now, it's a private site, correct?
It is a private site.
Which means
we keep it private.
They have to ask to join, and then they have to
Correct.
be admitted. Generally, what's
Correct.
the time between asking to join and being admitted?
I get notified by my phone that somebody is asking to be admitted, so I pretty much admit them right away.
Okay. And probably worthwhile going over a couple rules because it's important. It's private, but it's still public.
It's private, meaning that if somebody joins and they don't want to put their medical records out there, their other contacts aren't going to get their information. It's all within the group. So that way it's private.
And it's not really meant for political statements generally, right?
No.
Because we're coming up on an election year, and we all, I'm sure, have our own
we do.
opinions,
Yeah.
should I say.
Yeah.
But you really don't want that on there much, do you?
No.
You want to try to stick to the medical side of things, right?
Exactly. We want to stick to AFib, how to fix it,
right,
and what it's like before and after,
right,
and recovery period. Very, very supportive group. Very supportive group.
Yeah. For those of you who asked questions, they were all good questions. We tried to get to most of them. I might try to stick one more in here. I've been taking metoprolol blood thinner to help with my AFib. My AFib does not bother me enough to impact my daily routine, exercise, etc. I'm afraid of having a stroke. Are there other drugs I should discuss with my EP to manage the AFib? Well, boy, that's a loaded question. First of all, it'd be nice to know how much AFib that person's having. And what I do with some people is say, let's put the link in and see objectively how much AFib you're having. Sure. The Apple Watch is helpful, but it overreads a lot of things. The link is very objective, and the link will tell you each month what percent of time the heart's out of rhythm. What's the AFib burden? Is it 2%? Is it 4%? Is it 10%? And those kind of objective answers help guide your care, not only for your physician, but for yourself.
Can I see the information from the link on the dashboard? Or
Can you see the information? You cannot. Medtronic doesn't supply that. But what we have been offering patients is if you want the monthly readout, we'll send it to you.
Okay.
We'll do that for you.
Yeah, interesting.
The company doesn't offer it. So this is the kind of thing that's why we do virtual visits, to find out and ask more questions to really figure out what's going on and what medicines that person's already on. That's a complex question. Sandy, thank you so much for all the work you do. You're a policeman, you're a nurse, you're a psychologist on that site, and we owe you a great debt. A lot of gratitude from all of us for everything you've done. You've helped a lot of people. I think one of the people you've helped is in the room today.
Yeah, Sandy, that Facebook page is such a great resource. I mean, you're floundering out there on your own with no support or help because they've told you there's nothing more we can do for you. But there is salvation out there. And finding Dr. Wolf's YouTube videos and finding that Facebook page can make such a difference in people's lives. It's just wonderful.
Having 3 failed ablations like I did, I know what it feels like to lose hope of ever living a normal life again. And I think that's why I do what I do, trying to get that across to people, that there is hope. You don't have to live this way.
That's right. That's a good way to end. Thank you both for joining us. Mr. Producers, I think we're on again next month, first Tuesday, 5 p.m., and we'll tackle some AFib work. Thanks everybody for joining, and if you're in the Houston area, check out the rodeo. It's the best in the world. Thank you.
Bye.